Studies looking at the transcriptome have shown that you have reversal of many biomarkers that are increased or decreased. And when you look at these and the placebos on the left there, you can see the red, things that are too much, and blue, things that are underproduced compared to underproduced, that are just changed by the, I can't really see what's there, but in lesional skin with the 300 milligram, you could see it changes. You have before and after here, red to blue and blue to red. And then the latest studies, the solo studies that just came out, which showed that clear or almost clear levels at 16 weeks were clearly statistically significant in both studies, as was improvement from EASY. This was an interesting study because it looked at what will be the dosage, 300 milligrams weekly, and compared it to every other week, and really didn't see a difference. I think that I think that's wonderful because it suggests to us that at least in many of our patients, of course we haven't even started in kids, but many of the adults, you can maybe get them under control and then just maintain it there within every other week or maybe even less. The interesting thing is it seems to be pretty safe, but there is, in addition to injection reactions, one thing that's come out in these studies, and that's a higher risk of an interesting conjunctivitis, and it's not clear what this is. It's hypothesized to be an allergic conjunctivitis, but good ophthalmologic evaluations have yet to be done. So in conclusion for this set, it's increasingly clear that pediatric AD is a systemic disorder, several comorbidities, and our understanding the importance of the epidermal barrier and the mechanisms of immune action is really directing new therapies. So new topical and systemic therapies are undergoing testing in adults. We're just moving to adolescents for atopic dermatitis, and we'll have new options. I'll stop with that. Sorry to have to fly through, but a little overview on inflammation in kids.
So in our severe, I hesitate to contaminate the microphone. In our severe atopics, especially the little babies, we do exactly what you recommended the burst for. Will you try Translational because of the volume you can get?
Sure.
The one-time drug that's not special. But douse them in it. I tell the parents, you have no rules for this week. Put it on them once a day, everywhere. Vaseline like 6 times a day. Come back in 2 weeks, we'll talk about everything else. And I've talked to Adam about this, and I find that it's totally anecdotal. Those kids do not go on to be a subset ever as bad as I think they would have been if we didn't knock it out at like 4 months of age.
Right.
So as low as 2 to 4 months, I feel like anecdotally we have this window. If you just knock that down really hard, perhaps we can intervene. And
totally the experience that I have.
That's just
and I would say that 90% come in and respond fantastically. I mean, not everybody does. Small percentage that doesn't. And of those, I'm always, of course, these are the kids who've been to 5 other doctors before, and nothing's helping, and this and that, and they've already done this and that, and at least 50% barely have to do anything after. Right. And it's really
But I think in the babies it works better. So if you get a 6-year-old that's like identified, it's a mess.
Once you get, they already have pretty good epidermal thickening, because a lot of these patients had exactly that story. And now they barely have anything. They put a little here or there, or sometimes they're just using the low-strength stuff every so often. It absolutely is a disorder that's cyclic and built on itself. And if you can cut it off, and I feel the same thing too about jumping in there and treating. I think a lot of it is just reassuring that there's not any harm when you use it short term. It's all about maintenance and not continuing on a chronic basis. That's where potential danger comes.
Well, to your point, the education is probably more important than the prescription itself. Because if you with steroid phobia, it's documented. There's a British Dermatology article, that clearly delineates that patients are terrified of topical steroids, even though that fear is unfounded when used correctly. So it's really that first appointment, sitting down, going over everything, and then the soon follow-up right after, which is so important.
I think people who do well also spend that time, because if you don't have trust, it's all about trust. And the parents coming in and they may not want to do, they may be worried about it, but you have to, by the end of that session, have reassured them to do it. And if they do it, and of course, when you've been out for a few decades, it helps. You think, oh, I've had 30 years of experience, I've never seen this sort of thing. But nevertheless, it's all about the trust and getting them to do something, even if they were told, I'm going to use this for 3 days.
Right, but I also think the 2-week follow-up is very, like you said, because then you know, like, nothing bad can happen to you. People believe that for 2 weeks. And then, but I wonder is long-term, will they not get food allergies? Will they not get the other things?
Well,
if you get that,
that's why you have to do studies. I mean, we've thought, which we have this Pediatric Derm Research Alliance, we've thought about, we really need to prove this.
Right.
The problem is that I don't want to treat them any other way. I mean, I think it's so important in that window to try to knock it down and keep it down. But somehow that has to be looked at.
I know you're not the primary advisor for this, but in terms of the development of food allergies and now the shift to early exposure to allergenetic things like peanut, if parents speak to you about it, what are you recommending?
Well, I think that story is still playing out, but the recommendations are to do that early exposure, and so I think that's fine, except in the kids who are known to be have issues that would make that dangerous. So we're going along with what the allergists are telling them. I think it'll be interesting to see what that means. And I think part of the question is the role of skin and the role of barrier there, and how much of the development of the food allergies is from ingestion as opposed to exposure on the skin and all of that. So that remains to be played out, but it's interesting. We go through these cycles and how we deal with things.
How do we deal with those allergists who are telling us patients to do food elimination diets and are really pointing in the wrong direction, and they come to us and they're so confused they don't know who to believe because they heard one thing very different from allergists versus what we're telling them. An allergist gets upset because we redefine.
Well, I tell them what's out there in the literature, what's been really proven, and I never say anything bad about the allergists. I talk about how wonderful they are at handling this and this and this, but in fact, in this case, so I think it's very important to just tell them what's out there and what the experience has been, and always be, make sure that it's not done in such a way that allergist couldn't be a team player with you in helping with some of the others.
Yeah, I think it's a good idea to get them called allergists too and divide a joint team.
If you can do that, that's usually what happens is that the patient's seeing an allergist in our system, and we're always in touch anyways.
So I know it's been a long time coming for the biologics to be approved for kids with psoriasis. I appreciate all the work you did in pushing that forward. What about dupilumab in kids? I mean, atopic dermatitis, pediatric disorder. How far are we?
It's very interesting because FDA at different times has different, can be restrictive or can be helpful. And they're very helpful right now, the derm group, in terms of letting things move forward. And so we're seeing this huge shift to the point that they're encouraging getting into pediatrics as soon as possible, as soon as safe. I mean, it's got to be safe, obviously. But we've seen a real shift in that. So I think that this is going to go towards pediatric patients much sooner than the story of really preventing this from getting to pediatrics for years from the FDA. Now that said, there are protocols and it has to be done in a stepwise manner because none of us want to use this if it's not going to be safe in kids. At this point, we don't really think that in normal development, suppression of Th2 would be a big problem. It's been linked to the parasite type stuff, but that's not such a problem here in the US. However, that has to be seen. So the studies will be fast-tracked with respect to PK levels. You can do things where you kind of assume equivalence in efficacy, but you cannot assume safety. So they're moving into 12 years of age, and it'll be a 6 to 12 year PK assessment. Then there will be a 6 month to 6 year type thing. So that's how it goes. The question though is long-term safety. We're looking at PK levels, we're looking at the levels that we consider safe. We don't really know, and so the advantage of 15 years of etanercept being available for our patients, and we're using it when we can, and some of these others, is that we're really comfortable with this. We've got a lot of personal experience in large numbers of patients across the country. I think dupilumab for kids, assuming these PK studies and all look okay, is going to come out sooner, but it will be a relatively short window of safety, and we have to keep that in mind. Well, it's easy if you've got a $20-some thousand duometer.
Like, you know, we do newborn sedation.
Yeah.
Would it ever be something that would be available and things like that?
I think that it's not going to be with the way we currently do it, but you know, to develop like a little electronic sensor that you put on the skin, if it can measure that sort of thing, and you just stick it on there or whatever. I think in the future might be very useful, and in fact, that's something we're working on. So it's a very good question, but right now it's. I mean, I don't even know if you guys have a 2-ammeter. They're expensive.